the enzyme inhibitors like erythromycin will decrease the metabolism and it will increase the T-half. As I told you, it is having many adverse effects, and therefore its concentration has to be monitored. And if it is given with such kind of drug, then the concentration will be fluctuating, and therefore it will be essential to monitor the concentration. So where it is used as a second line drug is asthma. Why it is second line? Because I told you it has got many adverse effects, and therefore it is not as safe as the first line drugs are. Their example are the beta agonist, beta 2 receptor agonist. It is also used in status asthmatics. In our previous class I told you about status asthmatics. That is, status asthmatics is a condition which is very acute, severe attack of bronchial asthma, and it does not respond to the routine treatment. So in that cases, aminophylline is quite popular for this. It is the first choice in status asthmatics. So what are the problem? As I told you, it has got many side effects, and it has got a low therapeutic index. It has got low therapeutic index means it has got less safety, and because of the less safety or narrow safety margin, the theophylline concentration has to be monitored, the blood concentration. We have seen that there are interactions. Example, erythromycin, and erythromycin is very commonly used in bronchial asthma. So when the erythromycin like drug is given, it is an antibiotic, so it can cause decrease in the metabolism of theophylline, and thus theophylline can accumulate, and thus it can become toxic. So what are the effects, side effects? It has got serious effect like hypotension, arrhythmias, then GIT, that is nausea and vomiting, CNS effects, tremors, nervousness, insomnia, convulsion, etc. So because of this many effects, or because of this many adverse effect, it is put as a second line treatment. But as I told you, it is important drug to be considered for status asthmatics. Then next class of the drug are anti-inflammatory agents. I think yes, we stopped over here, and I asked you to go through this physiology of glucocorticoids, then mast cell stabilizer, leukotrienes, etc. Whether anybody has studied glucocorticoid, what are the actions they are having? No answers. Okay. So these all anti-inflammatory agents, they control the asthma. So we call them as a control medications. They are used for prophylactic. I told you the differences. There are two basic therapies. One is called as a prophylactic. That means it is a preventive. It does not allow the problem to occur. And another one are known as a therapeutic, that once there is a problem, then these drugs are helping to recover. Both have their own importances. So these are prophylactic therapies. All these anti-inflammatories are, they reduce the number of inflammatory cells in the airway tracts, and they prevent the blood vessel from leaking fluid into the airway tissues. Because of that, they reduce the inflammation, and because of the reduction in the inflammation, they will reduce the airway spasm, that is, or we call it as a bronchoconstriction, and also they can reduce the bronchial hyperactivity. So this is the basic mechanism these drugs are having. All these drugs are expected to do this, and thus because of the reduction in the inflammation and reduction in the overactivity, these drugs will be helping to reduce the asthma. So first of these is a glucocorticoid. We know that it is naturally secreted in body. It is an hormone from adrenal cortex, and since it is having impact on the glucose metabolism and it is a steroid in nature, they are called as a steroidal hormones, or these are called as a glucocorticoids, because gluco means it affects the blood glucose, and corticosteroid means these are the from the adrenal cortex and steroids. So we call them as a corticosteroids or glucocorticoids. The mechanism, there are multiple mechanisms they are having. They causes inhibition of phospholipase 2. This is the enzyme which is, I hope recently you have studied this in autocoids, that this phospholipase 2 that breaks down the phospholipids into this arachidonic acid. So if arachidonic acid is not formed, then its next product, that is prostaglandins and leukotriene, will not be formed. If you remember the next stages, that is, first is during injury phospholipids are exposed to the blood contains this enzyme phospholipase A2. Because of this phospholipase A2, the phospholipids are converted into arachidonic acid. This arachidonic acid is metabolized by two important enzymes. One is known as a cyclooxygenase that produces prostaglandin, and another one is known as a lipoxygenase. This lipoxygenase convert this arachidonic acid into leukotrienes. So this is the synthetic pathway. It blocks the first stage itself. So it decreases the phospholipase A2. So since there is a less, or it is the phospholipase A2 is inhibited, then it will not able to produce arachidonic acid. If arachidonic acid is not sufficiently produced, then it will not produce the prostaglandins and leukotrienes. Now here important is you must be knowing that prostaglandins play important role in inflammation, and therefore we use various drugs which are acting or which are called as anti-inflammatory agent, or we call them as NSAIDs, non-steroidal anti-inflammatory agents. So why they are called as a non-steroidal anti-inflammatory agents? Because these agents are not steroids like these glucocorticoids. Okay, and this, since they are not steroid, they are not acting as a corticoids. So they are called as a, and they are blocking the synthesis of the prostaglandins. They act as a cyclooxygenase inhibitors. Okay, so this is one of the important action, that is inhibition of phospholipase 2 is the important action of glucocorticoid. Another is they are causing the mast cell stabilization. Because of that, they will decrease the histamine release, they will decrease the capillary permeability, and therefore this will decrease the mucosal edema. They will cause inhibition of antigen-antibody reaction, and because of that, whatsoever inflammatory signals are there or chemotaxis is there, it will not be there. One more important function they have is they will upregulate the beta-2 receptors. Beta-2 receptor upregulation means number of beta-2 receptor in the bronchial airways or in the bronchi, they will increase. Because of that, this more and more drug will be able to act on this and will able to achieve more bronchodilation. So these are various mechanism of actions. Let us see how they are doing. So we have seen that there are membrane lipid, and membrane lipid is metabolized by phospholipase A2 that is converted into arachidonic acid. There are two important enzymes which are acting on that. So these are known as lipoxygenase and cyclooxygenase. So corticosteroid block this first stage, so there will be decrease in the arachidonic acid. Because of this, the next stages are there, that is lipoxygenase and cyclooxygenase are there, that will not be there. And in that lipoxygenase they produce hydroperoxidase, and they are also known as HPETEs, while this cyclooxygenase will produce endoperoxidase, and this endoperoxides, example of prostaglandin G, prostaglandin H, etc. Now this will able to give rise to prostacyclin, then prostaglandin E, prostaglandin F, and thromboxane A2. This is what we call it as a cyclooxygenase pathway. So from membrane lipid to arachidonic acid, and will make this type of endoperoxides. While another pathway is known as a lipoxygenase pathway. So here lipoxygenase will produce these hydroperoxides, and the product of these will be leukotrienes, example of LTB, LTC, leukotriene B, leukotriene C, leukotriene D, etc. Now out of that, this LTB, particularly LTB4, is highly inflammatory in nature, and it is predominantly present in bronchial airways. So this LTB will be activated, and we should have the drug. So here we shall see the drug that is called as a zafirlukast. That is zafirlukast is anti-inflammatory by causing antagonism of LTB4 receptor, that is leukotriene B4 receptor. Now very important concept I like to add into this. Suppose we know that, as I told you, the inhibitor of this cyclooxygenase, that is COX-1 and COX-2, we call them as NSAIDs, and they are NSAIDs, that means non-steroidal anti-inflammatory drugs. That means cyclooxygenase inhibitors, that is COX inhibitors or NSAIDs, they will reduce inflammation. So what will happen if we give these NSAIDs? Can we give these NSAIDs? What do you feel? No answers. Yes, you have studied it recently. If we use NSAIDs, what do you feel, whether it should help in relieving asthma or it should not? Yes, Pallavi said it will help. What about others? What do you feel? Yes, they will act as anti-inflammatory agents. So what they will do with bronchial asthma? What about others? Only two answers are there. What others feel? Yes, but your understanding is okay. It's correct understanding wise, but the problem, let me tell you what it is. I told you there are two pathways. Okay? There are, what are these two pathways? Arachidonic acid has got two pathways. One is known as lipoxygenase pathway and another is known as a cyclooxygenase pathway. One more thing I told you is in bronchi, comparatively the receptors for leukotriene B4 are more than anything else. So that means that if leukotriene is there, even small, and it is very very potent inflammatory agent, is LTB4. So if LTB4 is present, then it will cause bronchoconstriction. Now if we block this with the NSAIDs, whether it is blocking the production of arachidonic acid production is same, or it is decrease or increase because of that. When we block it with the NSAIDs, what will happen to arachidonic acid? Arachidonic acid is same, very good. Now earlier there were two pathways. Okay, suppose there was 100 molecules of arachidonic acid were there. So it was, and if it is, let us assume it was equally distributed. So 50 molecules of arachidonic acid were metabolized by lipoxygenase and 50 molecules were metabolized by cyclooxygenase. Because of this, 50 molecules of leukotrienes were produced and 50 molecules of prostaglandins were produced. Now we are blocking this NSAIDs with cyclooxygenase. So how many molecules of arachidonic acid are present? 100 molecules. Now these 100 molecules are available for metabolism by what? Because cyclooxygenase we are blocking with the NSAIDs. So they are available for what? Lipoxygenase. Now lipoxygenase, instead of 50, now it will produce more amount of leukotriene or less amount of leukotrienes? More. So what is dangerous? Leukotriene is dangerous or prostaglandins are dangerous for asthma? Yes. So what will happen? Can we use NSAIDs in asthma? So can we use? You understood why? This is the mechanism why NSAIDs should not be used in bronchial asthma. Although they are anti-inflammatory, although asthma is an inflammatory disease. Okay, this was one of my favorite questions. Asthma is an inflammatory disease, and if the patient is given with NSAIDs like aspirin or any other, what will happen? So these all NSAIDs are contraindicated in asthma. Some of time these NSAIDs are causing more impact or more we say that problem than curing it. I hope it is clear to you why NSAIDs are not used. Okay. So your earlier answer, earlier Pallavi and 2-3 students have given that yes, we can use. So although it is anti-inflammatory, although bronchial asthma is an inflammatory disease, we cannot use NSAIDs or non-steroidal anti-inflammatory agents. But can we use steroidal anti-inflammatory agent? Can we use steroidal anti-inflammatory agent? Yes, taking too much time. Can we use steroidal anti-inflammatory agent? Yes, We can use, why we can use, see this is a corticosteroid, this is the steroidal one, first one. So it blocks phospholipase formation, it decreases phospholipase, because of that it will decrease arachidonic acid formation. So when arachidonic acid is decreased, then both are decreased, lipoxygenase pathway is also decreased and cyclooxygenase is also decreased. But if we block, then indirectly we increase lipoxygenase, we block cyclooxygenase, then indirectly we increase lipoxygenase. So therefore we cannot block NSAIDs or we cannot use NSAIDs, or we cannot block cyclooxygenase pathway, but we can block phospholipase pathway, because, and that will be more what we can say, more effective if we block phospholipase A2. And therefore corticosteroids are very good anti-inflammatory agents, and they are one of the very important anti-inflammatory treatment in the bronchial asthma. So I hope you understood the basic mechanism. Definitely if you will read it, you will understand it in more way. Okay. So what are the action of glucocorticoids? They are anti-inflammatory. Then second beneficial effect they are having, particularly in asthma, they are immunosuppressant. We have seen that asthma is because of two things. It is immunological reactions and various what we can say, stimulant chemicals are involved. So we have got immunosuppressant effect. So this will not be there because of the anti-inflammatory action through phospholipase. It will produce less leukotriene B4. Then other effects are there, like it causes hyperglycemia, it causes increase in the protein catabolism, decrease in the protein anabolism. Because of the decrease in protein anabolism, again it will synthesize less amount of enzymes, and that will another beneficial effect, because many enzymes are responsible for making these inflammatory mediators. Okay. It can, this additional effect, it can also have mineral corticoid effects, like it causes fluid retention and sodium retention, it causes increase in the potassium excretion, so it can cause hypokalemia, and it can cause increase in the blood volume, therefore it can cause hypertension. So these are various effects it is showing. It also make the behavioral changes and depression like status. It can cause bone loss, and because of bone loss it will cause osteoporosis like action, because it inhibits the bone formation and it decreases the calcium this reabsorption or absorption of calcium. So it has got many side effects. Immunosuppression is very dangerous if it continues, because then the person become more prone for infections. And these corticosteroids, they have to be used very carefully, very cautiously, only if it is needed. And to avoid this, usually in asthma, where it is difficult to treat or it has got many problems, then it is preferred to use it in inhaler form. We have seen various inhaler, that is dry powder inhalation, that is DPIs, then metered dose inhalation, that is MDI, or nebulizers. What are the benefit? Then this will be, these glucocorticoids will be remaining in maximum concentration will be in the pulmonary area, that is in bronchi and lung, and thus it will have comparatively lesser adverse effect if we use it in the local use, that is in inhalation or nebulizer way. So this is how these are used. It is given by inhalation, it is given by metered dose inhalation, and it has got good first pass metabolism. It is best choice in asthma. It has got less side effect if it is used by inhalation. But if the asthma is not controlled, then we can give it by oral route or injection only, particularly for the patient which are admitted to hospital. And for orally, the drug which are preferred are prednisone or methylprednisolone. For parenteral, the drug preferred are hydrocortisone or dexamethasone. Dexamethasone is also available in oral preparation. And for inhalation, the drugs or the corticosteroids which are selected are budesonide, then fluticasone and beclometasone. These are various steroids which are preferred for inhalation route. So these are all glucocorticoids, and they are very important. As I told you, whenever the inflammation cannot be controlled, there is a very high bronchial inflammation. These drugs are of great importance in that, and therefore they are used in a prophylactic as well as in therapeutic purpose. So how they are used? They are not bronchodilator, but therefore in case of serious one, in case of acute attacks, one bronchodilator has to be given. Particularly we prefer beta 2 agonists, but yes, they can reduce bronchial inflammation to the many or very high extent. They reduce bronchial hyperreactivity to stimuli. This will be another beneficial effect they are having. They can cause the delayed onset of action. It takes around 2 to 4 weeks to show the action. That means, therefore, in acute cases, it can be this one. They are not much effective. The minimum action or the maximum action that takes place after 9 to 12 months. It can be given as a prophylactic medication. It is used alone or combined with beta agonist. Some of the actions are seen acute also. Example, decrease in the phospholipase or inhibition of phospholipase, etc. They are effective in allergic, then exercise mediated, antigen and irritant induced asthma. So in different kind of asthma, they are very useful, and if you will go through, then you will find that they are very important, or they are very important component in the bronchial asthma treatment. Then next is systematic. I told you that systemic corticosteroids, example those which are given either orally or parenterally, they are reserved for status asthmatics. So inhaled steroids are the best one for adults or for even younger children. The children with any of the following features, that is, they are using inhaled beta 2 agonist 3 times a week, symptomatic 3 times a week or more, or waking up then 1 night per week can be given. So those already using inhaled beta 2 agonist and have problem, then we can give 3 times a week these steroids. Then symptomatic 3 times per week or more can be given, and then those who are waking up, so during night it can be given 1 night per week. So these are normally used inhalation techniques for that. So when it is used, treatment of inflammatory disorders like asthma, rheumatoid arthritis, there are many inflammatory disorders where these are used. Now we will not study this at this moment in detail, only we will have this. We can have it separate one next year, that is, we call it as an immunosuppression topic. In that we will study it in detail. It is used in treatment of autoimmune disorders like ulcerative colitis, psoriasis, and other organ or bone marrow transplantation. It is used as antiemetics in cancer chemotherapy, but there are many side effects. It causes adrenal suppression, that is because of the presence of that. If you know feedback mechanism, if you have studied the endocrine system, then you know what is feedback is. So in feedback you will find that these drugs will cause the suppression of HPA, that is hypophyseal pituitary adrenal cortex axis. H means hypothalamus, P means pituitary, and A means adrenal cortex. So this HPA axis will not be functioning, because it is very important that whenever there is a stress is there, then because of this axis, this hypothalamus will sense it, pituitary will release the corticotropin releasing hormone, and because of that adrenal cortex will release this glucocorticoids. However, if the glucocorticoids remain present in blood as such, because of external administration, then it will decrease the release of corticosteroid from hypothalamus, and because of the prolonged use, body may not, or body will secrete very less amount of these steroids. And if these steroids then abruptly withdrawn, then body may not have sufficient amount of corticosteroids, because the hypothalamus is not because of the hypothalamus is not giving orders to pituitary, and pituitary is not giving order to adrenal cortex. So in that case it will be there. and that can be very problematic. So whenever these corticosteroids are there, it has to be uh, done in slow one. Then next is it can cause growth retardation in children. It can cause osteoporosis, that is the porosis means pores, or increase in the these holes, we cannot call hole as actually, or decrease the density of bone. Best way to describe is the bone density is decreased in osteoporosity. Then fluid retention, because of that, if there is a fluid retention, we have seen earlier, blood volume increases, and because of that it can cause hypertension, it can cause weight gain. Then it causes hyperglycemia, it causes susceptibility to infection. Just now I told you, because it is immunosuppressant, it can cause glaucoma, it can cause cataract, it can cause the fat distribution in improper way, and it causes the wasting of muscles. It may cause psychosis. Psychosis means situation like what we can say, psychiatric problem, where the person is having where their thoughts are changed, their minds are changed. That is psych, what we call it as. So psychosis means what we can say, people with improper mind functioning, or what we call them as a mad like behavior. So those which are behaving very abnormally, where abnormal mental function is there, we call them as a psychosis. So these are the effects. Already I told you, inhalation has got very less side effects. It may cause oropharyngeal candidiasis. Candidiasis is a fungal infection with Candida alba is a fungus. Why it will be occurring? Because as I told you, these agents will cause decrease in the immunity. So otherwise this fungal infection, which was not possible, it will be there. So this kind of problem will be there. It can also cause dysphonia, that is voice hoarseness or change in the voice because of the continuous. I told you about abrupt withdrawal should not be there. Abrupt stop of corticosteroids should be avoided, and dose should be tapered, that is slowly, because of adrenal insufficiency. I told you HPA, that is hypophyseal, hypothalamus, pituitary adrenal axis, HPA axis is disturbed, because when we are giving the external corticosteroids, body will not produce it, and all of a sudden if you stop, then there is no external and no internal corticosteroid is present, and we call it as a adrenal insufficiency syndrome, and it can be very dangerous. Then next is called as a mast cell stabilizer, next class of drug. These drugs are doing the mast cell stabilization. That means whenever there is any kind of foreign material comes, and these foreign substances, those which are having allergic potential, they will cause the initiation or stimulation of antibodies formation. This antigen antibody reaction will be there, and this antigen antibody will be taken up by cells. Particularly these are the mast cells are there. These mast cells are typically differentiated these basophils, and this will take up the antigen antibody complex and will release the histamine from that. Histamine is very strong bronchoconstrictor. So because of that, this bronchoconstrictor which is there, this bronchoconstrictor will result into this histamine will result into bronchoconstriction, and it can be a problem one. So these are the agents. They are acting by stabilization of mast cell, because whenever antigen antibody complex are taken up by the mast cell, this mast cell will cause sensitization, and because of that, there we call it as a degranulation. The granules are there, these granules will be degranulated, and from these granules histamine will be released. So when we give these agents, then they will stabilize this. This mast cell will not release their granules, and therefore no histamine will be released, and because of that this bronchoconstriction from histamine or histamine mediated or allergy mediated will not be there. But as I told you, this will happen when, or they are useful in what condition, that if they are given earlier, if somebody is going into the area which is he feels that he is prone for allergies, example dusty areas, and he knows that I am having allergy of dust, then if he takes it earlier, then it will be useful. But if it is taken after already asthma is there, it is not useful, because already mast cell is because of antigen antibodies, because of the allergies, histamine is released. It has caused bronchoconstriction, so it cannot relieve bronchoconstriction. In that case, you have to use only bronchodilator agents. Okay, this can only useful as a prophylactic use. It cannot be used in a therapeutic purpose. I hope you understood that since the drug is not useful to relieve the constriction which has already been caused, it can prevent the bronchoconstriction because of the histamine release from the activated mast cell. So it will stabilize mast cell so that mast cell will not be activated. If mast cell is not activated, it will not release histamine. If it is not releasing histamine, then histamine will not cause bronchoconstriction. But if already it has happened, if histamine is already released and histamine has already caused bronchoconstriction, then this drug has no use. So this drug is not having any therapeutic value. This is only useful for a long-term use as a anti-allergic, anti-asthmatic agent. So whenever such kind of allergic situations are there, body will not react strongly, because histamine or mast cells will be stabilized, histamine release will be less, and accordingly it will be there. Then it has got very less oral absorption, that only 10%, and it is usually given by inhalation route, that is aerosol or microfine powder or nebulizer. So they are not bronchodilator. I told you they are not effective in acute ACAT because they do not relieve the already bronchoconstriction is there. They cannot do it. They are used only as a prophylactic and not as a therapeutic anti-inflammatory agents or anti-bronchoconstrictor drugs. They reduce the bronchial hyperactivity, which is because of the histamine. They are effective in exercise, antigen and irritant induced asthma. Okay. Children respond better than adults to this kind of drugs, and that since it is less absorbed and maximum it remains into the pulmonary one, they are comparatively safer one. They have very lesser adverse effects. Prophylactic therapy in asthma, particularly in children, allergic rhinitis and conjunctivitis, in that it is used. The side effects is bitter taste and minor upper respiratory tract irritation like burning sensation, etc. But that is again minor. As I told you, this is comparatively safest drug, but not therapeutic, only as a prophylactic use. Then very important one are the leukotriene antagonists. They are produced by the action of 5-lipoxygenase on arachidonic acid. We have seen it earlier. They are synthesized by inflammatory cells which are found in the airways like eosinophil, macrophages and mast cells. The LTB4, that is leukotriene B4, is the most important one. It causes chemotaxis of neutrophils and it releases, or it itself is a bronchoconstrictor. Then cysteine leukotriene C4, D4 and E4, they causes bronchoconstriction, increase in the bronchial hyperactivity, and they causes mucosal edema, mucus hypersecretion. These all are the effect of the cysteine leukotriene. So these two are very dangerous, leukotriene B4 and cysteine leukotrienes, that is C4, D4 and E4. So all these can be inhibited if we can block the lipoxygenase. When we have seen this already mechanism, I told you this is a lipoxygenase. We have seen what are the impact if we block cyclooxygenase. This lipoxygenase is secreting, because of this lipoxygenase it produces hydroperoxidase, and this causes formation of leukotrienes, that is LT, B, C and D, and this particularly 4 in B4, C4 and D4 are very damaging in bronchial asthma. So we have got two types of agent, one type of drug. Example, if you go for one type of drug is there which is called as a leukotriene, which is called as a lipoxygenase inhibitor, just like we have got NSAID, that is cyclooxygenase inhibitor. Here we have got lipoxygenase inhibitor. The example of this is known as a xileuton. So it will not produce anyone. And the another one is there. These are the first one in that was zafirlukast, then montelukast, and many lukast are there. So these are actually blocker or antagonist of leukotriene receptors. So example of zafirlukast, montelukast, pranlukast, these are various lukast. They are selective reversible antagonist of cysteine leukotriene receptor, that is cyst LT1 receptors. They can be taken orally. They are bronchodilators. They have anti-inflammatory actions. They are less effective than inhaled corticosteroids. They have glucocorticoid sparing effects. We have seen that glucocorticoids are the best anti-inflammatory agents, but we have seen that it has got too many side effects, or it can cause immunosuppression. Now, if it is causing immunosuppression and the person is prone to have infections, then glucocorticoid we cannot use. So we can spare glucocorticoids. We will keep glucocorticoids away, and we can use this drug. So we call it as a glucocorticoid sparing effect. Okay, and it potentiates glucocorticoid action if we are combining it. So what are the uses? They are not effective to relieve acute attack of asthma, because already everything has been done. Prophylactic of mild to moderate asthma it can do. They can also be used in aspirin induced asthma. Then antigen and exercise induced asthma, they can be used. They can be combined with glucocorticoids, and because of it gives many benefits, it gives good effects, additive effect. The glucocorticoid dose can be reduced, and thus we can reduce the side effects of the glucocorticoids. What are the side effects? Elevation of liver enzymes, example SGO, TSGPT. There are many such enzymes which are there in liver. Because of that elevation, it gives signals like liver problem or liver damage. So that signals it will be given. It can cause headache, it can cause dyspepsia, that is indigestion. Then next kind of drug is called as a monoclonal antibodies. Whenever drug we see which are having in the end MAB, so this MAB means monoclonal antibodies. So there are many monoclonal antibodies nowadays are being produced. So this monoclonal antibody means using certain cells from animals and various microorganisms. The antibodies are produced against one or other kind of protein which is present in the body, and since they are using only one type of, then we call it as a monoclonal. So these monoclonal antibodies are there. Omalizumab is also one of the monoclonal antibody. It is directed against human IgE. IgE is one of the very damaging culprit. If you remember, or if you have any idea, we have seen it as a anaphylactic reaction. It is one of the very toxic, very severe action. Even patient may die during that, and these are all IgE mediated action. So IgE will be there. IgE will be, whenever there is a antigen antibody such complex will be formed, it will cause formation of IgE, and this IgE now will come into picture for actions. So this IgE is responsible for many allergic reactions. So when this monoclonal antibody is given, it will prevent the IgE binding with its receptors which are present on mast cells and basophils. They will cause decrease of release of allergic mediators, and they are used for treatment of allergic asthma. They are very expensive because they are new, and because of since they are very expensive, they are not the first line treatment drug. Okay, maybe in future slowly the cost will come down. So these are the Ig antibodies. They are binding to the mast cell, causes stimulation, and because of that it causes mast cell degranulation. If we block this, then this degranulation will not be there and the allergic response will not be there. Then another problem we have got, that is called as a COPD, that is chronic obstructive pulmonary disease. It is a chronic irreversible airflow obstruction where the lung damage and inflammation of the air sacs is there. If you have seen, please go through that drug, that is the disease that is called as emphysema. In Tortora, in anatomy physiology, you have read about it, and in that very nice description is given about bronchial asthma and COPD or emphysema. So these are there. It is because of the inflammation of the air sac. Mostly it is because of the inflammation is there because of the air sacs. The smoking is a high risk in this patient, and this because of smoking it ruptures the this alveolar alveolar walls, and this alveoli becomes the bigger one, which is decreasing the surface area, and therefore we call it as a barrel chest disease. The treatment are the inhaled bronchodilators, inhaled glucocorticoids, and oxygen therapy has to be given because slowly alveoli lose the capacity to inhale proper amount of air. So antibiotics can be given like macrolide antibiotic azithromycin to reduce the number of exacerbation during this. This is very good antibiotic. But if you remember, just now we have seen erythromycin, the parent molecule of azithromycin, erythromycin, they are from same class, and it causes the decrease in theophylline metabolism. It can cause accumulation of theophylline, and theophylline is that way having less therapeutic index. So that is dangerous with azithromycin, only thing. However, azithromycin is one of the very good drug if it is that way used alone, or it does not have much interaction with other drugs except theophylline. Then treatment for that is inhaled bronchodilators. There are many bronchodilators. Example are beta 2 or antimuscarinic. Antimuscarinic are superior in emphysema than that of beta 2 agonist. So we have seen epratromium and other. We can combine this salbutamol and epratromium, or we can combine this salmeterol and tiotropium. So these are the long lasting combination, salmeterol plus tiotropium, and it will be less dose required for that because both are given together. So this is what we have studied. These are what various drugs which are there. So basically there is some exposure to antigen is there. This causes it can be avoided if it is known. If it cannot be avoided, then we can go for the drugs like cromolyn, sodium steroid, xileuton, that will act as a prophylactic, and because of that it will not allow, if these drugs are taken, to synthesize leukotriene, cytokines, etc. And if it is done, then already there is a bronchial asthma, then we can have various drugs like beta agonist, theophylline, muscarinic antagonist, zafirlukos, they will be useful. And we can decrease simultaneously, we can use, there are two types of response are there, immediate or early response in bronchoconstriction, which is causing acute symptoms, and another one is known as the late response. So with steroid, cromolyn and leukotriene antagonist, we can stop this late response, and thereby we can prevent. So these are various drugs, briefly their mechanism of actions and how they are administered. So this is how one portion from the respiratory system is over. For other we shall see in next lecture.